Great. Welcome everyone to Massey Grand Rounds, and I think it's the fourth Janet Ressant lecture already. Wow, just keep going. It's great. Before I start, I'd like to start with land acknowledgement. This wonderful place, Massey College, is built on land that where many Indigenous peoples have lived and actually continue to live. It is on treaty lands and territories of the Mississauga of the Credit First Nation, as well as the traditional lands of the Huron, Wendat, Seneca, and Haudenosaunee peoples. We want to acknowledge our duty of stewardship towards the land and the great privilege we have to work and play, actually, on this land. Dr. Diosy couldn't be here, so I want to also welcome you on behalf of Massey College to this Grand Round event. I think I'll just make a couple of quick remarks about the topic of today and then turn it over to our two junior fellow co-leads who are doing a magnificent job as usual, just amazing. Of course, women's health is a very important issue. Sometimes it's a front page issue, and maybe not in a good way, actually, really. I'm a member of IMS, and our students put out this really wonderful magazine, IMS magazine. I'll try to show the light here. There it is. And the issue before the pandemic, so summer 2019, was actually on women's health, right? So it's a lot of student engagement with that. And again, I think it's a really great topic. And I think we'll have some reflections maybe on sort of the post-pandemic kind of what happened during the last few years and post-pandemic kind of consequences on women's health. So I'm going to introduce, really great pleasure to introduce both Robin and Georgia. So Robin's a PhD student in the Department of Immunology with a focus on viral-based gene therapy for rare pediatric diseases. She has worked in clinical research in pediatric oncology and is a second-year junior fellow at Massey College. Georgia Hedges is a PhD student in the Faculty of Dentistry under the supervision of Masha Muyedi, and her research aims to understand how pain, think about dentistry and pain, that's kind of an interesting combination. Okay, I get it. I get it already. Impacts cognition towards working memory and attention tasks, quantitative sensory testing, and echodermal activity. And Georgia is fourth year junior fellow at Massey College. So I'll turn over to the two junior fellow co-leads to continue. Thank you.
Good afternoon, everyone. Thank you so much for joining us today. It's a real pleasure and honor to be your co-chair this year. So we're going to start with our first speaker today, the Janet Ressant lecturer, Dr. Lorraine Lipscomb. The Janet Ressant Lectureship was established at Massey College in recognition of Dr. Janet Ressant's distinguished career as a scientist, scholar, a builder, and leader in medical research. This honorific lectureship will be awarded to accomplished young scientists to engage graduate students and faculty members alike as part of the Massey Grand Rounds MGR program. This year, the fourth annual Janet Ressant Lecture will be given by Dr. Lorraine Lipscomb. And Dr. Lorraine Lipscomb is a senior scientist at Women's College Research Institute and an associate professor at the Department of Medicine and Dalla Lana School of Public Health at the University of Toronto. Dr. Lipscomb is a physician scientist involved in health research, clinical care, and education, and leads an internationally recognized research program in diabetes epidemiology and health services, with a particular focus on the burden of diabetes in women. She's published over 100 peer-reviewed articles and led numerous research grants. She's also held many. She obtained her MDCM at McGill University in 1998, and she continued her postgraduate studies in internal medicine, endocrinology and metabolism, and clinical epidemiology at the University of Toronto. Dr. Lipscomb's current research includes a major clinical trial to study the prevention of the development of type 2 diabetes in women with gestational diabetes, or GDM. And Dr. Lipscomb is the inaugural director for the University of Toronto's Novo Nordisk Network for Healthy Populations. And this new network will unite academics with community stakeholders in Mississauga to address the burden of diabetes and other chronic diseases through community-based research. So Dr. Lipscomb's Janet Rossant lecture is titled Impact of Diabetes on Women Across the Lifespan. Dr. Lipscomb.
My microphone just came off. Apologies. Okay. How do I switch to the slides? Okay, thank you. All right. Thank you very much for that lovely introduction, and thank you for this wonderful opportunity to present to you today. I'd like to start by saying how deeply honored I am to be the recipient of the Janet Rossant Lectureship this year. Thank you to Massey College, to the Friends of CIHR, and the members of the advisory board for this wonderful recognition and opportunity to share my work. I'm incredibly humbled to be considered in the company of Dr. Janet Rossant, and who is an international leader, as you heard, in health sciences and a leading advocate for why health science is so important and why we need to invest in it in the society. Thank you, Dr. Rossant, for your advocacy and for being here today. Okay, just advance. Here are my disclosures. Oh, sorry. Okay, so my objectives today are threefold. First, I will try to illustrate how diabetes uniquely affects women. Secondly, I'll highlight through some of my research windows of opportunity to modify diabetes risk in women across the lifespan. And finally, we'll spend some time to discuss ways to tailor diabetes health services for women. So I'm going to start with a case. Now, this case is fictitious, but it illustrates a lot of the experiences and challenges that I've seen in many of my patients with diabetes over the years as a clinician. So meet Diane. Diane has type 2 diabetes and is 62 years old. She manages her diabetes with medications as well as insulin, and she has to check her sugar several times a day to keep her diabetes under control. She also takes, She also takes pills for her to keep her blood pressure under control, as well as her cholesterol. And in order to adequately self-manage her diabetes, she's also been recommended to maintain a healthy diet, to get regular exercise, and to lose weight. Now, Diane does find it challenging to meet these treatment recommendations. First of all, her traditional family actually expects her to cook more traditional cultural meals, and which aren't always compatible with some of the recommendations that are being given to her for a healthy diet. Secondly, even though she wants to walk, she has pain in her knees, which limit her ability to be physically active, and this probably is due to osteoarthritis that's not well managed. Thirdly, even if she did want to walk, as you can see from the picture at the bottom, she lives in a neighborhood that is really quite suburban and residential and doesn't have a lot of sidewalks or places to go. So she has to take her car to get anywhere. And speaking of cars, she has a full-time job, and because she lives so outside of the city, she has to commute 1 hour each way every day just to get to work in her car. And this leaves her little time for physical activity, for cooking healthy meals, and just for self-care in general, including adequate sleep. In addition to all of these roles and managing her diabetes, she's also a caregiver. You can see from the picture below, in addition, she has 2 adult children, one of whom actually still lives at home and requires some support, but she's also the main caregiver for her ailing mother, who has chronic comorbidities as well. So you can imagine, it's not surprising that, I'm really sorry. I don't know why I'm having problems. It's not surprising that Diane often feels overwhelmed, feels like she can't manage all of these competing responsibilities, and really feels like she's not able to do all the things that she's supposed to do, leading to feelings of depression, feelings of burnout, and she sometimes even doesn't even take her medications when she's supposed to. Now, one day Diane is having a shower and she feels a breast lump. And she becomes quite anxious, understandably, and thinks back, when's the last time I had a mammogram? And she realizes it's probably been years. Even though, as we know, after the age of 50, women are supposed to get screening mammograms every 2 to 3 years to help detect early breast cancers. She hasn't had one for years. She can't remember when. So she goes to see her family doctor. She gets a breast mammogram, and sure enough, she is diagnosed with stage 3 breast cancer and undergoes a lumpectomy. Following the lumpectomy, she is offered chemotherapy. She undergoes chemotherapy, and during that treatment process, her blood sugars become very out of control. Her diabetes is very disrupted, and she even has to go to hospital at one point to help bring those blood sugars down. Now, thankfully, she recovers from all of this. Her diabetes is under better control. She's given a good prognosis for her cancer. But all of these events have caused Diane to reflect on her medical history. Was there something that I could have done to prevent this? Was this due to my diabetes? What was I doing wrong? And was there something that could have been done to prevent my diabetes in the first place? And she thinks back to her last pregnancy, and she recalls that she had gestational diabetes, or GDM, which is a temporary condition of pregnancy that goes away after delivery, but she was told at the time that it was associated with a higher risk of getting diabetes in the future. However, after she delivered her baby, she was taken off all those medications she had to take. She was told that the diabetes had gone away, and she was discharged from care and no follow-up was offered. So this left her feeling abandoned and confused. What does this mean for me? What does this mean for my health? But she became distracted and busy putting her, with her new motherhood role, and so she kind of forgot about the diabetes. And sure enough, 6 years later, she got diagnosed with type 2 diabetes. Now, this case illustrates a lot of the reasons. Cases like these actually illustrate why I was inspired to actually look at issues related to diabetes in women, and what motivated me to ask some of those questions around the unique challenges that women face living with or at risk of diabetes. So diabetes affects over 1 million Canadian women, and 90% of those cases are due to type 2 diabetes, which is largely preventable with healthy behavior modification. Now, diabetes is in general more common in men than in women. However, work that we did years ago in Ontario found that although diabetes rates have been rising across all populations, the biggest rise was actually seen in young women under the age of 49. So this suggested to us that this is a group that we need to be looking at who are having specific impact of diabetes. Furthermore, this has been seen in other studies where there's been a bigger rise in diabetes in women compared to men in many low to middle income regions. And so this became another reason that we need to be looking more closely at understanding these unique issues. So diabetes can have impacts on women across many parts of the lifespan. So first of all, compared to men, women have unique risks associated with diabetes and may have higher relative risks of certain complications of diabetes. So for instance, in young adulthood, women with diabetes are more likely to have menstrual disturbances and infertility. As they get into more childbearing and pregnancy years, there's increase in pregnancy complications. And then after menopause and in older age, compared to men, women with diabetes are relatively at higher risk of mood disorders, cardiovascular disease, as well as vascular dementia. Furthermore, diabetes has been shown to be associated with a higher risk of several types of cancers. And for women in particular, diabetes has been associated with an increased risk of breast and endometrial cancer. And so these are some of the issues that are facing women that are unique to them as well as more common. But there are also critical, unique windows of opportunity across the lifespan to identify and reduce risk in women. And so there are early signs of metabolic risk which may emerge at critical life stages that offer this opportunity. So for instance, young women who develop polycystic ovarian syndrome and present with menstrual irregularities are known to have a higher risk of future diabetes, and so this could be an opportunity to intervene. Furthermore, a focus of my research, which I'm going to talk about and what we heard about in Diane's case, gestational diabetes, or GDM, is a condition that occurs in about 5 to 10% of women during pregnancy that also heralds metabolic risk and increased risk of progression to diabetes. So pregnancy is a so-called stress test for diabetes risk. And that's another opportunity to intervene. And then thirdly, at the time of menopause, we know that the insulin resistance and metabolic syndrome increases with the changes of hormones during that period. And some women may develop this metabolic syndrome and demonstrate an increased risk of progressing to diabetes. So yet another time where we might be able to intervene. And so my research has really focused on these two critical time windows, and I'm just going to touch on the two areas that I focused on in the last 15 years. So the first one relates to the relationship between diabetes and breast cancer after menopause. And so I'm going to talk to you about some of the work that I did in that area, but then I'll shift to work that we did looking at the earlier time in a woman's lifespan around pregnancy and the impact of gestational diabetes on future diabetes risk. Okay, so before I talk about some of the findings from my research, I'm going to start by just giving a brief overview of what the potential mechanisms might be that underlie the association between diabetes and several forms of cancer, with a specific focus on breast cancer. So type 2 diabetes is associated with two other conditions that are related that could increase the risk of cancer. One is insulin resistance and the other is obesity. Now, insulin resistance leads to what we call a compensatory hyperinsulinemia, especially early on, and even 5 to 10 years prior to the onset of diabetes, we see this hyperinsulinemia. And that is important because insulin is a growth factor for several cells, and this has been shown to promote the development and growth of several cancers, including breast cancer, through complex relationships that I'm not going to get into here. There's also an effect of adipose tissue. So there are many adipokines that are produced in women who have, or patients who have excess adipose tissue that may promote cancer risk. However, specific to breast cancer, we know that fat cells actually produce excess estrogen, and this can have actually direct effects on promoting breast cancer risk and poorer prognosis. And this is a particular concern for postmenopausal breast cancer, where they don't have the other source of estrogen from their ovaries. So when I was just starting my graduate studies, these relationships were just beginning to emerge and be described. However, we didn't yet have epidemiologic evidence of what the impact of these physiologic associations might be for women with diabetes. And so, you know, are women with diabetes actually at elevated risk of getting breast cancer, and how does diabetes affect their prognosis when they get it? So those were some of the questions that I sought out to ask during my graduate studies. All right. And so before I talk, sorry about that. So before I talk about what we found, I just want to briefly let you know about the data sources that we use to be able to look at these questions. So we were able to use population-based data from the ICES, which is a research institute here in Ontario that contains all the healthcare administrative data for the population of Ontario residents since 1994. Now, these databases are linked data on doctor visits, hospital admissions, prescriptions for seniors, as well as several disease registries. And in particular, for my research, I had access to a validated registry of people living with diabetes, as well as the Ontario Cancer Registry, which records the majority of cancer diagnoses in Ontario since 1967. So this provided a unique opportunity to start looking at some of these epidemiologic associations, as well as some health service implications of these associations. And so my research looked at how diabetes might impact the cancer pathway across all levels, from detection to diagnosis to treatment and survivorship. Now, I don't have time to tell you about all the work that we did, but I'll highlight a few key findings. So first of all, during my graduate studies, we did indeed confirm that compared to women without diabetes, diabetes was associated with a higher postmenopausal risk of breast cancer, with a modest but significant association, as well as an increase in breast cancer prevalence at the time of diabetes diagnosis. And that was important because remember how I said that hyperinsulinemia and insulin resistance can actually predate diabetes by up to 5 to 10 years. And so we actually wondered if that risk period actually predates diabetes as well. And so that indeed is what we found, and we've since explored that in more detail. But you know, we were some of the first to show these associations, and this has since been replicated in multiple studies across the world and now and meta-analyses, and it is estimated that there is a consistent about 20% increased relative risk of breast cancer for women with diabetes. So clearly not necessarily causal, but certainly contributing. We also were able to show that for women who developed breast cancer with diabetes compared to those without diabetes, they were more likely to die after diagnosis. They had about a 40% higher all-cause mortality. And that's since been replicated as well. And so that led me to look at another series of studies that tried to understand what are some of the reasons why women with diabetes might be experiencing higher cancer mortality. Is it because diabetes predicts poorer cancer-specific prognosis? And if so, is it because of health service gaps, such as delayed cancer screening, more conservative treatment selection, et cetera? Or due to more aggressive tumors, more aggressive effects of the diabetes on those tumors. And secondly, could there be a contribution of non-cancer survivorship? We know that people with diabetes and other chronic comorbidities are also more likely to just die because they have diabetes and they have complications of diabetes. So it could have nothing to do with the cancer. So we looked at some of those questions. And I'll just tell you about a couple of them. Sorry. There. Okay, so the first thing we did is we took a cohort of women with breast cancer and we compared women with and without diabetes and looked at their stage at diagnosis. And sure enough, even though it was modest, we did show that women with diabetes presented with a more advanced stage. And the reason why it's modest partly is because that was after accounting for previous mammograms. If we didn't account for previous mammograms, the risk was actually higher. So even though they were the women, even if we accounted for mammograms, there was still some residual effect of diabetes on the aggressivity of the tumor at diagnosis. Secondly, we were able to show, at least in women who had more long-standing diabetes, greater than 5 years, a higher risk of breast cancer-specific mortality related to diabetes. So certainly there was a contribution of diabetes specifically to dying from breast cancer, and that could be partly contributed to by breast cancer stage. We also looked at treatment patterns, and there didn't seem to be a big effect there. But then we started to wonder, well, what is the impact of cancer screening on this more advanced cancer stage of diagnosis? You remember the case that I told you about Diane. She had not had a mammogram in years, and if you asked her, it was because she just was so overwhelmed with everything she already had to manage with her diabetes, and probably her doctor was overwhelmed as well with the competing demands of her chronic comorbidities, that the mammograms got missed. And so we wanted to actually, early on, look at whether this was an issue by actually looking at this in the population-based data. And so, once again, early on, we were one of the first to show that compared to women without diabetes, postmenopausal with diabetes, women with diabetes were about 32% less likely to get a screening mammogram in any given 3-year period. And this was even after adjusting for a whole host of other factors, including seeing their primary care physician. And since then, that has been replicated in a number of studies. And actually, a nod to my wonderful PhD student, now postdoctoral fellow, Dominika Bhatia, who actually did a wonderful meta-analysis of this issue. And not only did she show that consistently diabetes is associated with lower screening rates for breast cancer, but also for cervical cancer in younger women. And when she looked at colorectal cancer screening, even though overall there was no effect of diabetes on colorectal cancer, in women specifically, when she stratified, the women were less likely to get colorectal cancer screening if they had diabetes. So clearly, cancer screening is, is suboptimal in women with diabetes. And so this really highlighted the need for us to raise awareness about the competing demands of chronic comorbidity and how this can actually distract from routine, effective preventative care. And so we need to find ways to create more coordinated care models and make sure that primary care is adequately managed even in the face of chronic comorbidity. Okay, so, oh yes. And so then finally, we also looked at the impact of diabetes and cancer on non-cancer survivorship. And so we wanted to know, after a person with diabetes gets cancer, what happens to their diabetes control? You remember that our patient, Diane, she actually ended up having a disruption of her diabetes management and actually ended up in the hospital. And sure enough, that's what we found in a study. We looked at diabetes before cancer and then just after a cancer diagnosis, and we saw, using some sophisticated modeling, that diabetic emergencies, hospital visits, avoidable hospitalizations, as well as cardiovascular events were significantly higher after a cancer diagnosis. And then finally, we looked at cancer survivors with diabetes, and we found that compared to people who didn't have cancer, cancer survivors were less likely to be treated with recommended medications that help save their lives and reduce cardiovascular risk. And so once again, we've shown that at least part of the increased all-cause mortality for patients with diabetes and cancer could be due to insufficient diabetes quality of care in cancer patients. And so this, again, is a wake-up call and a call to improve sort of coordination of care for people who have both diabetes and cancer. So to summarize, I've shown you evidence that diabetes is associated for women with an increased risk of breast cancer, more advanced stage, higher mortality, and that lower cancer screening and poorer diabetes care may contribute. And this really underscores the need for more coordinated care for patients with diabetes and other comorbidities. Let's not forget, my colleague Dr. Hawker is here, that we also need to think about how to manage things like osteoarthritis. We remember our patient, Diane, who was unable to do exercise because her knees hurt. And that really is also a failure of our system, because really there are ways that we can help manage a person's knee arthritis effectively. And in fact, walking is actually the first recommended treatment to help manage that pain. So that's also something that Dr. Hawker and I are looking at in a program to try and integrate osteoarthritis care with diabetes care, because this is such a common condition amongst our patients with diabetes, particularly women. Now, as we recall, the underlying mechanisms that underlie both the increased risk of diabetes and cancer can be targeted for prevention: obesity, insulin resistance with lifestyle modification. And these prevention strategies may be beneficial not only to reduce the risk of diabetes, but also to have an impact on cancer risk. So we really need to identify those windows of opportunity for prevention, given what we know about prevention and its ability to actually prevent the onset of type 2 diabetes and its complications. And so, again, thinking back to Diane, our patient, she had that opportunity when she had gestational diabetes to have more support that could have potentially helped her prevent or delay the onset of her type 2 diabetes. And so that's really the focus of my next phase of research, was really looking at that earlier point in a woman's lifespan to help identify that window of opportunity. Okay, so as I alluded to, gestational diabetes is a metabolic stress is a condition of pregnancy, and pregnancy being a metabolic stress test brings this out in about 5 to 10% of women. And even though it goes away in about 70% of cases, it is associated with a 7-fold higher risk of future type 2 diabetes, and 20 to 50% of the cases are actually diagnosed in the first decade. So it does rise early, so we need to intervene early. So it is an opportunity for diabetes prevention, and we need to capitalize on that opportunity. These are women who are actively engaged with the healthcare system, many of them because they're pregnant and they're actually getting diabetes care. Many of them are very motivated to improve their health and to engage in healthy behaviors for the benefit of their child. So we want to be able to capitalize on that as well. But there are problems, unfortunately. First of all, as I alluded to, what's very true is currently there isn't routine diabetes follow-up offered for women after gestational diabetes. They're generally discharged back to their primary care physicians, who are often strapped for time, who don't always have the resources to be able to provide effective lifestyle modification counseling. And even if they have access to services in that regard, the services that are currently offered have been shown to be insufficient to actually translate into meaningful health behavior change. And many times these women don't go to the doctor in the first place. They're so busy with their pediatric appointments with their new babies. Now, we also know that there are barriers at the patient level. And in the interest of time, I'm not going to tell you this, but we undertook a large cohort study where we did surveys, we did qualitative interviews to try and look at what are some of those barriers and needs for this population. And many of the findings that we and others have found, I've listed here, that the majority of women are not even aware of their higher risk of diabetes. And they get sort of a mixed message and false reassurance when the diabetes goes away after delivery and nobody follows them. And even if they were aware, they have limited time, limited energy, childcare commitments, a lot of competing demands. And then there's also the role of gender. So there's increasing evidence that the role of mother, or the maternal role, beyond just the sex issue of being a mother and having delivered a baby, but actually that maternal role often competes with self-care. And so women put their family and their children first, and self-care comes last. And so the recommendation specifically for women to address this issue is to help capitalize on their maternal role. And one example could be by saying, you need to serve as a good role model for your family. So if you're not going to do it for yourself, do it for your family. So those are some of the kind of strategies that we need to be thinking about to address some of these gender issues. Okay, so currently really a missed opportunity for diabetes prevention. So we weren't happy with that, so we actually wanted to really create a program. And we wanted to create a program that was both feasible for women, feasible for the healthcare system, but was also effective at helping women make behavior change, was accessible in women who have a lot of competing demands, and addressed all those unique issues for women. And so we created the Avoiding Diabetes After Pregnancy Trial in Moms, or ADAPT-M. And that program was based on a cardiac rehab model that was at Women's College Hospital that was built for women, as well as evidence from the literature of what would be effective. And so this is a virtual program which gives women a certified diabetes educator health coach for 6 months during the postpartum period, around 3 to 6 months postpartum. They get customized diet and activity education, as well as coaching for behavior change, so goal setting, motivational interviewing. And the key here is that it's all virtual, and they have regular scheduled telephone follow-up over that 6 months to help them advance their goals and help keep them accountable. And that has really been shown to be key. And so we did 3 phases to test this program. The first one was just a proof of concept where we brought women into the cardiac rehab program, and we showed that there was high adherence and actually improvements in fitness in a small group of women and high satisfaction. And so we thought we were on to something. So we then got some further funding from Diabetes Canada, and we created the program. We exported it out into diabetes education centers in the community, and we piloted it for feasibility and acceptability. And we were able to show that there was a 70% retention, which was actually really good compared to the literature for this population, and high satisfaction. And importantly, the program delivery was low resource and feasible for healthcare providers with a mean of 18 minutes call duration. And so we then enrolled a subsequent further number of women and got CIHR funding to test the effectiveness in a randomized control trial on short-term outcomes of diabetes risk. We're still evaluating the data for that. We just finished the trial, but again, we showed 70% retention. We've started doing some participant interviews, and our data analysis is currently in progress. So I'm gonna end this by just reading you a couple of quotes from our interviews with the participants. So overall, I think I had a healthier post-birth experience because of it, because it's just a reminder, right, that you were part of this program. And when a baby is born, you just devote all your resources to the baby and you kind of forget yourself for a while. And being part of the program, it was something like I could think a little bit more about me and also think about, yeah, I need to be healthy. I need to try and be the best for me, best me for my baby. And sorry. This is another quote, and actually speaks to the fact that 70% of our women were non-Caucasian and over 50% were immigrants to Canada. This was my first time, you know, being pregnant and experiencing gestational diabetes at the same time, because my husband and I are immigrants and we have no support here in Canada. And I knew that at the end of my pregnancy, I need support. So, you know, our program was not just helpful to help women, you know, focus on their self-care and help them prevent diabetes, but also to provide that more sort of emotional and other support that they need and navigation of resources. Okay, so I'm gonna summarize this part and maybe take a minute after just for one final thing. So I hope I've convinced you that GDM is an opportunity, a unique opportunity in women to identify and reduce risk. But the current problem is that postpartum follow-up and counseling is poor, and 20 to 50% of women progress to diabetes by 10 years. And so we really need effective, accessible prevention strategies that address unique barriers and needs of new mothers using behavior change techniques. And we've shown that telephone-based coaching is actually a feasible low-resource option, but that frequent follow-up and personal accountability is key. Many people have tried apps, and asynchronous coaching doesn't work as well. Our women have told us that actually talking to a human being and having those scheduled follow-ups is really key. It's a little bit more resource intensive, but I feel very strongly that this is one of the must-haves for this kind of program. And I hope that we can show that as we analyze the data. So I'm going to finish off. Oh yes, there's one thing I wanted to say. So this is a step in the right direction to be able to create a program that will help women improve their care and provide them with support from the healthcare system. But we also need to recognize that there are many factors that go beyond the individual and even the provider's control. And as we saw with Diane, there are structural and social factors that have contributed to the rise in obesity and diabetes in many societies that make it actually really difficult for people to make healthy choices. And so if we're truly going to meaningfully prevent diabetes, we need to address the upstream social and environmental factors that are often beyond not only the control of the individual, but the control of the healthcare provider. And so we're really fortunate that thanks to a donation to the University of Toronto last year by Novo Nordisk in honor of the 100th anniversary of the discovery of insulin at University of Toronto, we now have an opportunity to do just that. I am very honored to have been named as the inaugural director of this network, which is a cross-disciplinary research network at the University of Toronto to reduce the burden of diabetes and chronic diseases through better care, lower risk factors and healthy living conditions. It's a partnership between Temerty Faculty of Medicine, Dalla Lana School of Public Health, and the University of Toronto, Mississauga, which will allow us to work in a particular community to look at the ability to co-design community-based solutions for chronic disease that can then be scaled to other communities. And so the community that was chosen for this network was Mississauga and the region of Peel, where diabetes rates are very high and there are a lot of social and environmental determinants of health that need to be addressed. And so this is my sorry. And so this is a busy slide, but it's just to illustrate the complexity of the work that's ahead of us. We now have the opportunity, as I said, to go beyond the individual and to work with stakeholders and across all settings. First, the healthcare system, where people seek care, to make care more coordinated, accessible, and integrated. The community, where people spend their time to be able to integrate healthy behaviors and address the specific social determinants of health in high-risk groups in their workplaces and their schools, and finally to neighborhoods and communities where people live, to be able to create healthier environments that will make walking easier, healthy foods more accessible, so that the healthy choices become the easier choices for the whole population. Oh, and I will end there, my last slide, to thank the whole host of people, and I'm sure I've forgotten people here, who have worked with me on this work over the years, my collaborators, my students, my research team, my funding support at the bottom. And I also want to say a special thank you to some of my mentors who've really inspired me to ask the hard questions and then find the methods to answer them. People like Dr. Jan Hux, Dr. Jillian Hawker, who's here today, Dr. Paula Rachon, Dr. Paula Harvey, and many others that I'm sure I've forgotten. So with that, I will end. Thank you very much.
Do we have any questions for Dr. Lipscomb?
Thank you, Dr. Lipscomb, for that very insightful presentation. A lot of work has gone into what you just presented. I just picked up a couple of areas of the research identified that you have raised critical concerns around how lack of assessment of cancer risk among this population. But with such an astonishing data and statistics you have, given what you found and now what has changed, I would like to see how your data is translating into clinical care and what they actually changed. And secondly, I was wondering, given that some of the concerns you've raised around GDM post follow-up seem to be within primary care, do you think some of the crisis we're seeing right now is associated with the lack of that follow-up, and what are your suggestions to kind of ease up that and see how some of these post-discharge counseling can follow up at primary care? Thank you.
Thank you for your questions. Let me see if I can address them each in turn. So regarding your first question around what has changed and how has the research that we showed early on around breast cancer screening has translated into changes in practice. So around the time that we first identified the gap in cancer screening for patients with comorbidity, there was the launch of the Ontario Breast Cancer Screening Program. And that program has actually been beneficial in taking the onus off the primary care physician to remember to, and the patient for that matter, to remember to get their regular screening tests, and allows for automated reminders and follow-up that makes it easier to avoid missing those screening tests. And in fact, we did look again at cancer screening rates in a later period when more of these women were going through the Ontario Breast Cancer Screening Program. And the association between diabetes and breast cancer screening was actually much more modest in the more recent times, was around It was still significantly lower, but only around 7 or 8% lower. So we think, and we were able to show that that was really driven by more use of the Ontario Breast Cancer Screening Program. Now, I'm sure there's lots of other things that we need to do, and that I can't claim that that was, launched because of my work, but I think that it is an example of how just, improving sort of health system factors, I think, go a long way in helping to address some of these gaps. With respect to your second question around gestational diabetes and primary care, so that is a big challenge because primary care physicians are not always informed of what happened to their patients during pregnancy. There isn't really good communication, and we have a primary care physician in the audience who can speak to that it really depends on, it's all over the place, the communication between specialty services and primary care. And that is a huge problem that needs to be addressed around the world, across Canada, in Ontario, to be able to improve that sort of transition of care between specialty programs and primary care. So that's the first problem, is that primary care physicians aren't even always aware that their patient had gestational diabetes, let alone they need to be screened. And so there are some really proactive teams around the city that I've worked with that actually have a mandate. They send a letter to all the primary care physicians and keep them abreast. But that's only part of the problem. The patient also has to go see her family physician to be able to get that screening and get that follow-up. So, and that isn't always happening. So those are the kind of things we need to try and address, and it's not an easy solution. Go ahead, Stephen.
Very interesting. So we can look at this paradigm several ways. You choose one way. So you have a disease you call gestational diabetes. I'm not know much about that. I assume it's defined by a certain blood test, which would
Yes.
be hemoglobin A1C or insulin or fasting insulin, some kind of glucose thing, right?
Yeah.
So you call that a condition, which is gestational diabetes predisposes to cancer or diabetes. Well, we just did a big study on platelets, okay, big study published in JAMA and stuff, and we call it thrombocytosis, which is 450 plus, or we can call it elevated platelets. We call it a biomarker.
Yep.
So we have a biomarker called platelets. You've got a biomarker called HbA1c.
It is a biomarker.
But you choose to take the medical approach, which say I define a clinical condition, rather than use insulin or HbA1c as a biomarker for future condition. So I'm talking now at Women's College Hospital about integrating a bunch of biomarkers into predicting future cancer. I would say, okay, I would take it, and everybody gets this, and everybody gets, take platelets, white blood cells. So I want to add in such a study, this biomarker, rather than partitioning it into a bunch of different women with different medical conditions at different stages of their lives, a more simpler, and thereby kind of facilitate the kind of thing you're trying to achieve by. So it's a biomarker or is it a disease? I don't get it, because all I see is a biomarker, because these women don't feel sick, right?
So that's a really good point, and in the interest of time, I couldn't really kind of go over what happens when a woman gets diagnosed with gestational diabetes. But every pregnant woman gets this glucose challenge, which is like a stress test for their pancreas, and then we test their blood sugar 2 hours or 1 hour later, and depending on, there's a second test if they need it. But bottom line is blood sugar goes up, they get diagnosed with gestational diabetes. And the reason for the diagnosis is not because it's a biomarker for future diabetes for mom, but it's actually an impetus for them to be treated during their pregnancy to help reduce risks to the baby.
I'm just asking, can
Right.
I take a blood test out of ISIS or HOLIS?
Oh yeah, we have that, and in fact, I didn't talk about this, but we're just now in the process of developing a risk prediction tool for future risk of diabetes in postpartum women, and we're incorporating that glucose test as one of the biomarkers, and we're not calling it GDM or no GDM, we're just looking at the continuous glucose. So your point is very well taken. Thank you.
Any more questions?
Congratulations both on your award and a brilliant exposition.
Thank you.
Type 2 diabetes and obesity coexist more often than not. The risk factors associated with diabetes and those with obesity overlap tremendously. In your science, did you distinguish the difference between the risks associated with obesity in the absence of diabetes, and that with diabetes, to determine what the incremental effect of diabetes is on top of the obesity that coexists.
That's an excellent question. One of the problems with population-based data is it's broad but thin. So we don't have population-based data on body mass index and obesity. However, we do have it for the subpopulation, for a majority, not the majority, but a good portion of the subpopulation who've had a pregnancy through the BORN database. And so we're actually starting to look at the kind of contribution of both BMI and glucose and other factors on future risk of diabetes in a woman who's had a pregnancy. But other studies have looked at teasing out the effect of diabetes and obesity on the risk of cancers. And in fact, there is a contribution of both, but obesity seems to have the bigger contribution than diabetes. Yeah.
Just take one more question. Oh, thanks for your presentation. That was wonderful. I guess, okay, if I have to choose one question, I have a few. Might you elaborate on why you think there was such a big difference between the women who had diabetes and the care that they received for cancer versus whatever your comparison group was in that study?
So you mean when they had higher risk of diabetic complications or higher breast cancer mortality?
When they didn't receive the optimal care compared to the control group.
Very good question. Very good question. Yes, that was something that we were only able to hypothesize about. That our best guess is that cancer becomes one of those, cancer survivorship becomes one of those factors that also may distract from adequate quality of care for non-cancer conditions. That's our best hypothesis. But of course, to really understand that, we would have to then go to the next step and actually ask providers, ask patients, better understand what are some of those reasons why cancer survivors, might be less likely to take the recommended therapies. I didn't get into it because of time, but we also looked at this effect in specific cancers, and indeed, it was more salient for the more aggressive cancers, the ones that have poorer prognosis, such as lung cancer and hematologic malignancies. Whereas in breast cancer, we still saw that effect, but it wasn't as salient.
All right, thank you for your questions. We'll have a panel discussion at the end as well, so any burning questions you can ask then.
Great, thank you.
So on behalf of Friends of CIHR and Massey College, I want to congratulate you on Janet Prasad election. So there's a small token of our appreciation for that. It's a virtual check, so the check is in the mail. And I'd like to call on Dr. Rassam to present you with a plaque.
Thank you.
I get the honour of giving you the award, so congratulations, Lorraine.
Thank you so
And
much.
a great talk. Thank you very much indeed.
Thank you.
Picture.
Thank you so much.
All right, thank you very much, Dr. Lipscomb. So moving on to our second speaker today, Dr. Tanya DeRena. Dr. DeRena is an anesthesiologist and pain doctor at UHN. She has an interest in administrative leadership and has been leading the Toronto Academic Pain Medicine Institute for the last 4 years. She's also the co-chair of the Ontario Chronic Pain Network and Ontario representative of Pain Canada. She is the proud mother of 2 children, Rosa and Lily, and her talk will focus on chronic pain, sex differences in diagnosis and management of chronic pain, and the state of female pelvic pain management in Toronto, titled Women's Problems.
All right. I didn't have anywhere to clip the mic, so I got to use this one. All right. So, welcome to my talk. I called it Women's Problems, and I'll tell you why a bit later. My name is Dr. Tanya Drena, and I'm an anesthesiologist, so if you fall asleep, just leave your health card out and so I can bill for it. But I'm the medical director of a program called TAPME, and we are a partnership amongst the 5 academic institutions. There's 7 different pain clinics, and we try to work together as one. And at Women's College, we have our central triage and our interdisciplinary pain program and hub services, we call it. So if you want to learn more, we have a great website called tapmepain.ca, and we also have a lot of our health discipline material there too. So I have my own land acknowledgement, so thanks for giving it. I have my own reconciliation, so every time I give a talk about pain, I donate to Women's College Hospital Foundation, and I direct that donation to Indigenous healthcare. And these are my own objectives for giving a women's related healthcare talk. I'm a widowed mom of 2 young girls, and 1 in 5 Canadians has chronic pain, so I give this talk for them too. And I give this talk for Sophie, my patient. And Sophie is a 26-year-old patient. She's my Diane. She had cyclical pain since she was 14, was complaining to her family doc about it, and then started complaining about dyspareunia when she started having sex at 19. And then when I met her, she was 27. She was a competitive swimmer but had to stop competing. She had endometriosis in her lung and had a pneumothorax and had residual chest wall pain. So I always think about Sophie when I think about women's pelvic pain. There you go. So I made this slide in 2010, and it hasn't gotten really any better. So veterinary students get 5 weeks of pain management, and med students used to get 1 week in 2010. Now we get 2 weeks, which is really great because we have a world-renowned program run by the University of Toronto Center for the Study of Pain that runs the Pain Week. And it's an interdisciplinary pain program, which is world-renowned, and I think it's fabulous, but it's still only 2 weeks. So you should go to the vet if you're having chronic pain. So I'm going to give you, I have some objectives. So my objectives are written more like how I see objectives written. They're like, I'm going to bore you to death with some definitions. There's going to be some boring parts about pathophysiology, and then there's a fun part with sex differences in pain experience and manage. And then we're going to try to learn how to do less. And there's a meme that says, chronic pelvic pain, allow me to talk down to you for 10 minutes, and then I'll prescribe you an antidepressant. So hopefully we could do less harm. Sorry, I try to make it entertaining because the word pain is actually derived from the Latin word for penalty. So if you ask people who are survivors of cancer and have a chronic pain condition, they feel like they're being penalized maybe for having a condition or having survived cancer. It's very interesting, the psychology behind having a chronic pain condition. But just so you know, that's where it comes from. It wasn't just you, Dr. Lipscomb. It's actually this. All right, we're going to try to... Okay, no, don't worry. It's exciting. That's why it's jumping ahead. So acute pain is a good thing, right? It's adaptive. It's there for a purpose. It's there to warn you that there's something wrong. And acute pain is good, but it follows a trajectory that the pain, as the tissues heal, right? You have surgery or you burn your finger on the stove, and the pain goes away as the tissue heals. You get a blister, it heals, and then it's adaptive. It makes you like stop and protect that area so you don't get infected. It's an open wound. Don't get infected. Have some antalgic movements. But chronic pain is maladaptive. It actually persists long after the tissue is healed. So you're still doing acute pain activity even though now you have a chronic disease. So it's a disease in its own right. And believe it or not, the ICD, the International Classification of Disease, this year, so it's COVID and then chronic disease. So chronic pain. So they recognize chronic pain as a disease this year. Isn't that exciting? So we've only been talking about it for hundreds of years. But chronic pain, chronic primary pain, and chronic secondary pain are now diseases in the ICD with their own code. So very exciting for us. When I explain it to patients, I'm going to explain this to you because people don't even know kind of how chronic pain happens or what it is. I'm going to try to see if I can make it clear. So let's pretend you're cooking on your stove. I have a lot of cooking analogies because I'm Italian and I don't cook, so I feel very subconscious, feel very guilty. So I think that's why you didn't give me a mic either. You thought I'd be loud. But so you're cooking on the stove, and let's say you get distracted, you go in a different room, and then you have the little fire breaks out. And thank God for that alarm bell, right? That's pain. It's a good thing. It's trying to tell you, hey, pay attention, right? Go, call the authorities. Let them help you out and do something. supposed to be snazzy slide. Call the authorities to do something, right? So that's acute pain. Very good. Good for you. Keeps the population alive. Because if you don't do anything about it, it might get out of control and you might die, right? So chronic pain is actually pain that keeps going when it shouldn't, in the most case. So when you don't have any active fires like rheumatoid arthritis or lupus or things that cause active disease, chronic pain keeps going when it shouldn't, okay? It's a broken fire alarm bell, but it makes you think there's a fire. And so that's what people show up and keep showing up to your door for as a primary care doc, right? They're like, look for my fire. And then you have to try to tell the patient, no, it's something wrong with your fire alarm bell. It's not, you don't have a fire anymore. The problem is that, I wish I could give this talk without slides, is that patients love to, they want to find out why they had that fire, because that's the kind of thing they can explain, right? And in medicine, we're taught to look for fires. Like all of our imaging is taught to look for fires. It's really good at picking up things that can kill you, but not very good at things like chronic diseases, right? We're not very good at following chronic diseases or managing chronic diseases. So if I burned and my alarm bell keeps going off, I'll take my stove to the stove repair person. I'll say, hey, can you look for the fire? And our repair person or the doctor will look for the cause of the fire and says, hey, there's no fire here. And maybe I'll send you to a specialist, and the specialist always finds like some little thing that maybe has nothing to do with the fire, right? So maybe if you change the light bulb, it'll stop burning, and that never works. And the whole problem is that people with chronic pain, they've stopped cooking, right? And everyone in their house is going hungry, and that's the problem, right? You've stopped using your stove because maybe it doesn't feel like it works well, but the main problem is the broken fire alarm bell. And that's what chronic pain management is. So you got to learn to use your stove again. And people are always looking for a quick fix, right? So we all have like Aunt Tina, like I do, who always, has these suggestions that don't work. But people want that. So they don't want to really believe that it's a broken fire alarm bell. And chronic pain management is all about teaching people how to live despite a broken alarm bell. And so it's all about quieting that alarm. And a lot of the proven mechanisms of quieting that alarm is teaching people about that alarm and teaching them to manage their expectations, right? We can't make the alarm shut off because the alarm is your brain. So we also try to teach people through physiotherapy and OT to use their stove, all right? And to love their stove and keep cooking. Because there's no fire, there's no active fire. And sometimes you have to stop showing your stove your stove to repair people because you'll find stuff, right? So I love this slide. It's an old Sports Physiology Journal article that I still have on my desk, and it shows that, if I MRI'd Dr. Lipscomb's knee, she would probably have some cartilage damage, and if I were an orthopod, I'd say, hey, let's go in there and shave that. And now you got a hot knee that's already having pain, and you're going to find some cartilage damage. We know this because whether you have pain or not, you're going to have cartilage issues. And now we're going to go in and put a Roto-Rooter in there, and then we're going to wonder why I still have pain. And you're like, well, we sent you to enough stove repair people, right? So at the end of the day, we have to manage chronic pain like it's a chronic disease, and there's no cure. And we can't treat it with acute pain management principles, which we were doing for the longest time. So sometimes we treat chronic pain with like frequent injections, which is like the equivalent of going to your family doc for a rapid insulin injection, right? How good is that for long-term management of a chronic condition? It's not good. And so we do have chronic disease principles that we should be using to manage a chronic condition, and there's a whole manual written about it. And I'm sure everyone's read it, and it's all about self-management, and there's behavioral modifications and education. But a lot of it involves active participation of the patient. And a lot of it is actually non-pharmacologic therapy, which I even hate that word because it's like, it sounds like you're offering something less than the pharmacologic therapy, right? Even the word non, it's like, can I have a Diet Coke? And we're like, well, we have non-Diet Coke. And then you're like, well, I just want the Diet Coke. So we have to teach people how to quiet the alarm. But, it's a pill culture. People do want something magical to cure their ailments, to cure chronic pain, and we can't. So I just wanted to talk about a lot of factors influencing pain. So it's not just kind of, your primary afferent going to your spinal cord, crossing over and sending the message up to your thalamus, and then it goes to a bunch of areas in your brain. There's a lot of other factors that influence pain. Pain, by definition, is an unpleasant sensation and emotional experience, right? And the sensation, as scientists, we're like, oh, give me your pain score out of 10. That's something we can measure. But emotion is not really something we can measure. And it is both that experience. It's subjective. And it's layered with a lot of things, like all the memories and things you associate it with in your limbic system. So it's influenced by thoughts and feelings and stressors and certain behaviors. And some of these things are controllable and some of these things aren't. And other things I want you to think about for factors influencing pain is that it doesn't always mean the same thing to all of us. So our lives are very different, and that's the subjective part. And so when I told you that pain is a warning sign, it means threat, it means danger. And so some people don't feel, whether it's the color of your skin or your sexuality, don't always feel threatened, right? But somebody who always feels threatened, whether it's where they grow up or where they live or who they are, they're going to perceive threat all the time. And they're going to be really good at perceiving threat. So we have to think about that too when we manage chronic pain. And then there's, we're giving a talk about a woman's healthcare. There's always this, there's a lot of data around sex disparities in pain experience and management that came out in the last 10 years. Nancy Watt-Watson did a great study on CABG surgery, so coronary artery bypass surgery, big cut in the thorax, and a lot of disparities between the way men and women are managed, their pain is managed. So female sex are half as likely to be prescribed pain meds as their male counterparts for the exact same surgery. They're more often prescribed sedatives for pain in CABG surgeries. So it's a very significant paper for us. Another few significant articles that were published was around emergency room wait times for females with chest pain. So they're going to wait 15 minutes longer before receiving analgesics than men. And women are 7 times more likely to be misdiagnosed and discharged in the middle of having a heart attack. And so this is always concerning from a pain management perspective. There's a lot of disparities in the population. So we know for sure that females, there's a greater pain prevalence in the female sex. But pain intensity is inconclusive. So those studies that compare the exact same surgery, some studies will tell you that females experience more pain. Some studies will show that females experience less pain. But we know for sure that there's a greater pain prevalence for chronic pain in the female sex. And so there's a couple of explanations. There could be biological mechanisms and there could be some psychosocial mechanisms. So the biological mechanisms are that hormones are big influencers in how we perceive pain. And we've known that just from observational studies. So we know that women in the luteal phase, when your estrogen is slightly higher than your progesterone, it's pronoceptive. You feel more pain. We also know that in some studies, especially animal models, that testosterone is actually antinociceptive. So we see this in a lot of animal models where animals are either injected with testosterone or given topical androgen gel, that they perceive less pain stimulus. So testosterone seems to have this protective effect, and we see this in some of the pediatric data with childhood migraines. So children before puberty, the prevalence of migraines will be equal in boys and girls, and then when they hit puberty, it triples in females and then decreases by half in boys. So an indicator that hormones have something to do with how we're feeling pain. This is just a great little paper in Nature about sparrows, and they were giving them testosterone, and they were dipping their feet in hot water, and the testosterone would prevent them from removing their feet. So really cool studies. And so a lot of, in the last couple of years, we've started seeing some use of hormones to manage pain. So using topical testosterone for looking at fibromyalgia, et cetera. So I mentioned sex disparities in pain management and pain, the prevalence of pain. But there's In the psychological data, you'll see a lot of psychological mechanisms being suggested for why pain is more prevalent in females. There's this psychological construct called catastrophizing, and I thought this was all about like being Italian, like being catastrophic, and I realized, oh, it's like a psychological construct. So pain catastrophizing means you ruminate, you magnify, and you feel helpless when you have pain. And the more you catastrophize, so the higher you score on something called a PCS, pain catastrophizing score, the higher your level of disability. And so when they have sex difference studies, there's women demonstrate higher rates of catastrophizing. And there's also a self-efficacy score called the SEQ6. And this is the belief that one can successfully perform a behavior to achieve a desirable goal, and then men actually demonstrate a higher self-efficacy. So a few disparities there. And it, you know, when you see these studies, you think, okay, like, why are we catastrophic, right? Like, because maybe no one listens, right? So I don't know. Maybe there's a few other reasons that are suggested too. But I always think about Sophie, like maybe had she gotten a transvaginal ultrasound or an MRI or that been known, she wouldn't have to become so catastrophic and her pain made worse, et cetera, et cetera. But that's, I think, okay, maybe she called the authorities and maybe the authorities weren't listening. I don't know. Is it parenting? In a lot of the psychological data, we realize that we don't tolerate a lot of physical risk taking with our daughters. And I realized that as a mom of 2 daughters, but I don't have a boy to compare with, but it does exist in the data. And, mothers and fathers are more likely to engage in rough and tumble play with their kids. So they kind of make these tough little boys, right? And then there's a theory that women are often exposed to environmental stress much early. So there's an earlier onset of cyclical pain with menarche, so primary dysmenorrhea, exposing females to prostaglandins and interleukins much earlier, maybe causing some level of central sensitization. And then there's this other theory about females experiencing more ACEs. It's not a theory. Females do experience more ACEs. And if you don't know what ACEs are, Oprah's been talking about it since 2002. And so ACEs are adverse childhood experiences. And this is a busy slide, but it's the ACEs slide. And it's some traumatic events that have negative and long-lasting effects on health and well-being. And there's 13 elements. And if you have 4 or more ACEs, you're more than likely to develop some mental health issues and chronic disease, and more likely to have an earlier death. So 4 or more ACEs, if you have at least 1 ACE, you're 67% more likely to have chronic disease. So females are more likely subject of physical, sexual, and emotional abuse. The other elements are neglect, so emotional neglect, physical neglect, and then household challenges. So now what? I mean, I'm the medical director of a program. It was my duty to clean house within our own program and across Ontario. So we recognize the program. We have a central triage where we physically looked at how many of our patients are female and male. And we had 70% of our patients were female and 90% of our providers were male. So we made a concerted effort to hire more female providers. And directed towards more female pain programs. We also, I'm also the co-chair on the Chronic Pain Network in Ontario. So I work with the Ministry of Education to create education campaigns that are suited to the education system. So we're trialing a new education campaign about resilience, self-esteem, and the impact of ACEs. And we are trying to address women's problems at very early ages. So a lot of education plans in primary care. And that's it.
Thank you so much. Do we have any questions? Okay, I'll just come over there.
Hi, I don't think I've met you, but I'm Jillian Hawker. I'm at Women's, but I'm never at Women's, and that was fabulous.
Thank you.
It's just so wonderful to see somebody talk about chronic pain as chronic pain. I've got lots of laudatory comments, but my question
Yeah,
is...
I love that.
Yeah,
Supposed-
I'll give
it's supposed
it
to
you
do that.
after, okay? I'm a rheumatologist. I've done osteoarthritis research. What I'll ask all of you guys about is the hierarchy of conditions and treatments that you've all laid out, because it's really, OA and pain are right at the bottom there. My question is that the case that you presented was a young woman with endometriosis, but you defined chronic pain as pain when there shouldn't be pain. Surely she had
Yeah.
chronic pain.
For sure. So she had endometriosis, which is one of those kind of lupus, osteoarthritis, rheumatoid loop, kind of those, they cause ongoing destruction. But
We're calling her somebody that shouldn't have, somebody
no,
that shouldn't have.
no,
an
it gets a
alarm
bit
going off.
confusing because I think had we treated Sophie in our young adult clinic, she might have felt more, she might have had less PTSD when encountering the healthcare system because
Right.
she just stopped going to physicians after.
Right.
And the way I found her is actually she was sent to me with chest wall pain because she had a chest tube from, you have these rare cases of endometriosis going
Yeah.
into the lung, but she's like, listen, I've been telling somebody about this for a long time.
So her alarm was intact.
Yeah.
Nobody was paying attention to
Correct.
it.
Yeah. Yeah. Very different. Yeah.
Stephen Nayrod, also at Women's College Hospital. Enjoyed your talk. So I'm thinking about an experiment maybe we could do. So
Let's
you
do
take
it.
a bunch of undergraduate students and you put them in a room and you give them a pain. I don't know, some kind of a,
Yeah.
on their fingers.
Hot water is usually the
Hot
warm
water.
Yeah.
Yeah. And then you ask them, but you give exactly the same stimulus. I don't know if that's possible, but.
Yeah.
And then you ask them to rate it on a scale of 1 to 10 as severity. Would you see a difference in the men and the women?
You might.
That's not a.
It's not a very scientific answer, but
is
we'd
it
have to do the
I
experiment.
mean, it
And to
seems
be
like a pretty straightforward experiment, no?
pain severity, like for the same stimulus, okay, there's a few studies that are done with a similar notion. Pain severity studies are notoriously inconclusive. Like if there's a meta-analysis that show that pain severity with the same surgery is, some of them say women feel more pain, some of them say males feel more pain. A lot of it is controlling for factors like who's delivering the pain meds, because that was another study. Males will complain less about pain when there's a female providing the pain meds than when there's a male. There's all kinds of little confounding factors. So it's an interesting study, but I think it's been done. Yeah, I think it's been done. Yeah. You're also not controlling for a lot of things, like I mentioned about factors influencing pain, right?
Right.
Yeah.
Excellent presentation. Enjoyed that immensely. I wonder if you could describe what the natural history is of chronic pain at different age of onset. And if in later years, chronic pain and dementia supervenes, does it change the perception of pain in that situation? So 2 questions. Chronic pain, age of onset, when it's seen, and secondly, the impact of dementia on that syndrome.
That's a great scientific question. And I have to be honest with you, chronic pain is a new specialty. I mean, I just told you, we just made it, and it just has an ICD code. So even collecting data was very difficult because people aren't actually outrightly diagnosed with a chronic pain syndrome. So I'd have to look that up. I honestly, the periods of life is very interesting because we don't really have that information. We do have a lot of information on young adults in terms of perception and affiliation with young adults who have chronic pain and healthcare PTSD. There is some work that's being done there.
Thank you. I'm John Flores. I'm a cardiologist, but I do end up getting a lot of patients with Ehlers-Danlos, hypermobility, and postural orthostatic tachycardia syndrome that have chronic pain. So this is something that I've tried to grapple with because I've had great difficulty finding individuals to help deal with the pain. But about 30 years ago, I did some research looking at the impact of acute exercise on the central endorphin pathways. and found that this was a very effective way of engaging mu receptors within the cortex and brainstem, and wondered whether in your list of antinociceptive interventions, you mentioned testosterone, but tell us about exercise.
Oh, for
And
sure.
Tell us about the role of exercise in your program.
So we do have an exercise program. So we have a physiotherapist guided exercise group. And we run 7 of those a month. They're very well attended. Exercise does release beta endorphins, which act like opioids, same receptors as opioids, and it actually releases endocannabinoids. So little marijuana your body makes. So release of lots of good things. And we know this. I mean, you know, when you look at beta endorphin data, there's beta endorphins released prior to childbirth. So we know it's there to decrease pain during childbirth. So even in acute phases, you'll release your own beta endorphins. But yeah, that's actually quite well known that it does release beta endorphins. I don't know if you wanted me to tell you anything else besides.
No, I just wondered if you're engaging in exercising programs.
Yes. So I'll explain to you. We have a hub program, and our hub program means we sit at Women's College. It's got all the health disciplines. We have about 15 health disciplines who run interdisciplinary programs. So it's psychoeducation and cognitive behavioral therapy, and then exercise therapy. It's a 9-week program. It's called Pain University. We run it like a university, have a graduation ceremony, and it's similar to, it's all in person. It goes to virtual now during COVID, but we've brought it back to a lot of in-person programming. And we use this, we have a lot of data coming out of this Pain University program about exercise and CBT and coaching. And I think you wanted to mention.
Thanks. It was a great talk, and oh my goodness, what a topic. Thank you. But it occurs to me there's a lot of people in my primary care practice that I would see who have chronic pain, suffer with chronic pain, and could not attend an in-person clinic. So I'm wondering what kind of resources might be in, sort of down the pipe for people like that, because they really are suffering, and there's limited amounts that you have to offer them.
Yeah, so so I work at the Ministry of Health. We've come together, we have 19 funded pain programs across Ontario, and we've created something called the Power Over Pain portal. It's coming out during Pain Week on November 6th. November 6th is National Pain Week, and it is a portal that patients can enter, and if they have access to a computer, they can have a list. They'll enter all their conditions and it'll give them kind of a tailored list of videos to watch, of exercises to do, and of lessons about cognitive behavioral therapy. A lot of it is asynchronous, and we're trying to create a sub-portal with synchronous workshops. So all of the 19 ministry funded pain clinics are responsible for 1 workshop a month. So hopefully we'll have 19 workshops a month that are synchronous. There's also a lot of LIN activities. So the Living Healthy, we've given our program, Pain U program, for them to give it online. So they do it online. If you look at your local LIN and choose the Living Healthy programs and enter chronic pain. So there's lots of online stuff, but we'll try to make it more public. We have a public awareness campaign coming up on November 6th. Yeah, very exciting.
Wonderful. Thank you so much,
Thanks.
Dr. Durena.
Thanks.
Thanks very much again. And our last and final speaker before the panel today is Dr. Sheila Dunn. Dr. Dunn's an associate professor in the Department of Family and Community Medicine at U of T, a scientist at Women's College Research Institute, and the associate director of research for Canada's Contraception and Abortion Research Team. The focus of her research and academic activities is abortion, family planning, emergency contraception, and the implementation of programs to improve equitable access to reproductive health care. Her talk today is going to discuss mifepristone, COVID, and the transformation of abortion in Canada. Welcome.
Yeah, thank you. And now for something completely different. And thanks for inviting me. Many years, too many, I don't even want to say. I lived next door at St. Hilda's for 2 years, and one of our favorite things was to try and peer into Massey College to see who the heck was in there. We knew Robertson Davies was in here, but I'm so thrilled to be in the hallowed halls that I, for so long, actually thought about. It's as beautiful as I thought, but thank you. Anyway, I'm going to change gears a lot here and talk about mifepristone, which is something I've worked with for a long time. COVID, which seems like a bit of a stretch, and maybe it is, and the transformation of abortion in Canada, which has really happened. So I'll see if, oh, yes, I'm having the same trouble. Sorry. Oh, now I got nothing. Okay. I receive research support from the Department of Family and Community Medicine at U of T and Women's College Research Institute. I have no conflicts to declare with this presentation. So I'm going to go back. It's brief. It's a brief back in time to just a little bit of history of abortion in Canada for those of you who might not be familiar. The picture on the right is a book that was very popular when I was in university, Our Bodies, Ourselves, made by the Boston Women's Health Collective. And it came out in the early 70s at a time when women were really starting to reclaim control over what was happening with their bodies from a medical point of view, etc. And this was kind of happening a bit in Canada in the same way, in parallel. Up until 1969, abortion was illegal, as was contraception. And it was legalized in 1969, but only in certain conditions. The abortion was legal if it preserved the life or health of the woman. It had to be provided in hospitals, and it required the approval of a hospital committee of doctors to say that this person, I was on these committees, they'd present the story of the woman, and you had to say whether she deserved an abortion or not, and fell within the sort of the parameters of what the law said. If we fast forward to 1988, there was the Morgentaler decision. Now, in between 69 and 88, Henry Morgentaler, who was probably the most famous doctor in Canada, actually, during the time he was around, started to open up abortion clinics. He opened them up in Montreal, in Toronto, and subsequently in other cities in Canada. And the reason he did that was that hospitals, which were the only place you could get abortions, did not provide sufficient numbers to be able to serve the needs of the population. So he opened clinics and did abortions in clinics, but that was illegal. And he was charged many times. He went to jail a number of times. Henry always said, a jury would never convict me, and they never did. But the Crown did keep appealing it, and it went all the way to the Supreme Court. And the Supreme Court ruled in favor of Morgentaler and said that the criminal law violated the Charter of Rights, and in the sense that it violated the right to security of the person, of the woman. And so abortion at that point was decriminalized. There's no criminal law on abortion, which is very unusual worldwide. There's a couple of other countries like that, but we are one of the few. I'll see where I can go with this, sorry. Whoops, let me see if oh man, okay, sorry. I'm gonna fast forward now to 2016. There was a little rocky period in the 90s, though, where there was quite a lot of violence associated with abortion. The Morgentaler Clinic, which was on Harvard Street, just the other side of Spadina, was bombed. His clinic in Montreal was set on fire, and one provider in Hamilton was shot. Another one in Winnipeg was shot, and Gary Morales in BC was not just shot, but later on was stabbed. So there was quite a lot of violence going on. This was in the 2000s, but things settled down, if I would say. And we were always hoping to get mifepristone during that period of time. But I'm going to take you up to 2016, which is around the time we did. And this is sort of the picture of what was going on here then. We know that about 1 in 3 Canadian women have abortions in their lifetime. That's a lot. That puts it in the almost normal experience thing, if you think of 50% being normal. But in terms of it's normal. 100,000 abortions per year on average. About 96% were surgical, so we had virtually no medical abortion being provided. We didn't have the drug that was used for it. We did it in other ways. Almost all were first trimester or early abortions. 2/3 were provided in abortion clinics at that point, and 1/3 in hospitals. So the clinics were doing a lot of work at that point, but they're only located in cities. And most of those cities are along the U.S. border. So if you lived in remote areas or areas outside, your access was really impaired or could be impaired. So it really wasn't uniform across the country. So much so that the UN Human Rights Commission called on Canada to improve inequities in abortion access. Sorry. I can blame my thumb. Oh. It goes all or none, eh? I want that slide. Sorry, that one. Oh, man. Okay. This is the pill that changes everything. It's an old slide from Time Magazine. It's the year 2001, I think. That's when imifepristone was approved in the U.S. And you can see that they thought it was going to be revolutionary there. We didn't have it yet, but I would say it's been pretty revolutionary here. And just to give you an idea what it is, it's actually what we have is a combination of mifepristone, which is an anti-progesterone. It blocks the action of progesterone, which is the hormone that supports early pregnancy. And then it's followed 24 to 48 hours later by misoprostol, which is a drug that was developed to actually protect the stomach from substances like aspirin and things to protect them. But it also causes contractions of the uterus, and that's a byproduct of it, and it's probably mostly now used for gynecological reasons. But it causes the uterus to contract, and then the pregnancy is expelled in a process that's really like a natural miscarriage, basically. It's used up to 10 weeks of pregnancy, and probably further, it's used later in pregnancy for other indications, but in terms of early abortion, mostly up to 10 weeks. Okay, so used globally, and I feel like I'm missing something there, this one. Just to give you a sense of where things were globally, you can see Canada's in teal. That's 2015 when we had approval, but we were really late coming to that. It was first approved in France and used in France in 1988. So all those orange and red color, all those countries had it way long before we did. We were late to the game. Now that was always disappointing for us, but in fact, we had so much evidence around how this drug worked, and there was so much use of it that we had a lot of, we could learn from what happened elsewhere. The way it's used globally, particularly in Western countries, is that there's almost always some kind of restriction on it. Either an abortion law that's still in existence that interferes with how abortions can be provided. There's limited in some way. Where they're provided, so they're often like centers that are abortion specific in terms of what their function is, and they can't be done outside that. Who can prescribe or dispense, and where the drug must be taken. Now in the UK, not until recently, a woman had to go in and get the pill in a clinic, and then she had to come back 2 days later to get the second pill in the clinic, which is used either vaginally or buccally. And sometimes she'd have to stick around, but then she could go home. But this is a process that could easily be done at home. So where the drug was taken was quite restrictive in some ways for people. Okay, let me see. Sorry. Okay, the initial Canadian approval actually had similar restrictions, similar to the US and Australia. And probably the reason for that was that when it was put into Health Canada, these were the things that had already been approved. It wasn't a big stretch. We weren't asking for anything more than what had already been approved elsewhere. So I think there was some thought that it would be easier to get it through and approved in Health Canada. But the restrictions were similar, so that you had to be trained on this mandatory training program to be able to prescribe it, or if you were a pharmacist, to be able to order it. And once you were trained, you then had to register with the company that supplied it, and only then would they either honor your prescription or provide you with the drug. Completely different than anything else, any other way we do things here. Only the prescribing physician could dispense it, so the pharmacist could not dispense it, didn't have the safety of having a pharmacist knowing what they're doing and providing the medication. The ingestion had to be witnessed, and an ultrasound was required. And fortunately, these were the restrictions that came in with the approval in 2015, but mifepristone it wasn't available till 2017, so there was a little something we thought we could get together to do to potentially change some of that. One of the things our group wanted to do was really to support the diffusion of mifepristone abortion into community primary care. We know about the problems of people who live in remote communities and geographic areas where there's no coverage. If this could be provided by a community primary care provider, a person could get an abortion in their own community from their own doc. Much simpler, much better access. So we actually got funding for a study that looked to identify barriers and facilitators to implementing it and really to try and address some of the supports that might be needed. We had a virtual community of practice, which now has about 1,500 or so members that provided all sorts of practice supports, billing codes, what are the regulations in your province, ask an expert if you have a question, etc. And it also collected information from people who were on the virtual community of practice about what problems they were having and interviewed some of them. And we fed that information back, particularly to Health Canada, because they were interested and they were one of our knowledge users on this grant, in an attempt to really try and address some of the barriers that were interfering with it being rolled out. So since approval, and the first thing to go was the observed dosing, which makes sense. There was a lot of press about how paternalistic this was, that we were going to make women sit and take a pill in front of someone who could watch them take it. And there was some sort of, oh, well, we didn't mean that from Health Canada. And that was reversed. And by November 2017, we found that at that point, prescriber training was no longer mandated. I mean, when you think about it as a clinician, we don't take things on that we don't feel like we don't have the aptitude to do. That's just part of, there are all sorts of things that we take on that are new. We learn how to do them, or we don't do them if we don't know how to do them. So this was sort of a unique thing related to this drug. And it's not mandated now, but it's expected that you know what you're doing, just as you would with any other thing you're doing clinically. Don't register with the manufacturer. In fact, that was actually not legal to do in Quebec anyway. If you were a physician, you couldn't do that. And pharmacist dispensing is permitted. And I think that was probably the biggest change that enabled this to get out there beyond clinics and hospitals in terms of the way it's delivered. It's a regular prescription now. They've expanded prescribers. Nurse practitioners decided they were going to do it, and they did. And they kind of did this before they were even, from a federal point of view, allowed to do that. But their provincial colleges said it was okay. Increased gestational age limit, and the drug costs are covered, which is fantastic. And they're covered in a way that we can track the drug. We know when it's being dispensed, and we've got, it comes through the system in a way that we can actually know how many doses have been dispensed. And now ultrasounds are no longer required. They weren't being done all the time anyway, because we always do things we do a lot of off-label stuff when we practice anyway. Sorry. There, okay. So, good opportunity to get this out there. We wanted to know what happened when it was available without the restrictive regulations. We were unique in a way, in this sense. So we did a study that looked at the outcomes. What was abortion utilization and what's the safety? If it's not safe to get it out there more broadly, then we need to rethink how we're doing this. We're looking at workforce and access, and we're going to be looking at abortion costs. So this is just, it's a slide that shows the change in the medical abortions that occurred between 2012 and the year 2020. So this is an interrupted time series of abortions in Ontario. We used ICES data, so we collected, we identified all the abortions that occurred each year during that time period, their providers, who was the provider, and what percentage were medical, which we knew because we have the prescription for the mifepristone. And we looked for outcomes like hospitalizations, repeat procedures, et cetera, et cetera. You can see that medical abortion increased from 2.2% in the mid-period of the first sort of period pre-mifepristone to 30% in that period, which is in that upward line. I wish I had a pointer, but the line going way up, which is the period post-mifepristone availability when the restrictions were removed. And by the end of the period, it's about 40%. The abortion rate did not change. Now that was important, probably not in Canada, but this has been important thinking in the US that if you make this easy to get, the abortion rate's going to go up. And for some people in the US, that is not an acceptable thing, even though it might mean that people who don't have access are getting access and get what they need. Nevertheless, the abortion rate did not change. So, and more, as importantly, severe adverse events were rare and they didn't change over the time period. You can see this line is completely, almost dead flat. No increase in adverse events, such as hospital, ER visits, et cetera, or in ectopic pregnancies. So again, it's safe. We then went on to take a look and see what, just do a survey of Canadian abortion providers and what their practice was in 2019. So this is kind of the tail end of the period that I was, or the mid part of really of the period that I just showed you in those graphs, but pre-COVID. We don't know what the denominator is in this case. We don't know who provides all the abortions in Canada, but we had 465 respondents to this, and they related a number of abortions that they provided that we estimated was about half of the abortions in Canada. They said they related that they provided about 28% of their abortions were medical, and these were more in rural areas than urban areas, which is kind of what we're hoping might happen in terms of getting it out there. Primary care clinicians, they're providing most of the abortions. Almost all of them are offering medical abortion, and 70% exclusively medical abortion. So they probably were not providing abortions before. They were probably not doing surgical, or they would have probably continued to do some of that. But definitely we think there are some new providers in there. I can't tell you how many. And nurse practitioners provided 2.4% of all the medical abortions. Sorry. Okay. So just to summarize, the impact of mifepristone availability without restrictive regulations, we saw a rapid increase in the use of medical abortion for early terminations, an increase in the number of providers, particularly in community primary care, more rural providers. And the question is whether this is going to give people better access or not. It'll certainly give them more choice, I think, but whether the access, how much the access changes, we don't know. And importantly, no change in abortion rate or safety of abortion. And this is important because this deregulation that we have here could go on in other countries that are interested in this, and the safety aspect is important. So we have data that is, we are kind of unique in some of the data that we have in Canada because of our linked data at ICES and how we collect it. I'm just going to go quickly on now to, oh, I'm going the wrong way, sorry. We don't want to do that. It's hard enough to go forward rather than back. Okay. So I'm just going to bring, this is just something that happened that I think has made a change, and it's made a change in the way we provide all sorts of care, but it's moved abortion care and is moving it quickly into a different realm. So COVID, stress on services, hospitals were tied up, there was social isolation, we were trying to avoid unnecessary in-person visits for care. And there was really an uncertainty about the demand for abortion. We thought it might go up. We thought unintended pregnancies might go up. People were home all day. In fact, the pregnancy rates went down. So maybe you don't love the one you're with that much, I don't know. Right early on, the Society of Obstetricians and Gynecologists of Canada made a statement that induced abortion is an essential medical service that must be maintained. We were cutting a lot of stuff. They acknowledged this was essential. And they also said that medical abortion should be offered as a first-line method of induced abortion rather than, you can balance it with surgical, but that potentially it might fall out that it was safer than surgical in these situations. And they went on to, we developed some low touch, what we call low touch, no touch medical abortion protocols that could be provided through telemedicine. And when I'm saying low touch, I mean, they may have no contact with a physician or clinician. They may go to a lab. No touch is they don't have any testing and just do a virtual visit. That's it. Which relies a lot on us making sure that we think they're within the gestational age limits. There's no big problem with it. But history taking it's amazing how good you get when that's all you can do through virtual means. We did take a look at what people thought who were working in abortion, what was happening during the pandemic. And this was a mixed method study. And again, they reflected our community. In our community, we've considered abortion and contraceptive care to be an essential service and have made sure access continued throughout COVID restrictions, just as we had hoped and was important to do. Okay. Half of the respondents said they increased the volume of the medical abortions they were doing. They did note, and we saw this at the Bay Center, there were fears of patients about coming for care. They didn't want to come in. They wanted to stay home. They didn't want to be seen. There was some reports of difficulty getting procedure room time for surgical abortion. And notably, almost 90% were offering some or all abortion care virtually. So many tests, like ultrasounds, which were routine pre-COVID, were being only done if indicated. So if you go to a clinic for an abortion, you're going to automatically get an ultrasound. They've got one there, you're just going to get it done. When stuff's done virtually, you're going to do without that unless you think there's a need in terms of the history or what you're hearing, that you feel like you need to have an ultrasound to know what's going on. They also pushed up the gestational age limits that people who were doing potentially second trimester abortions who were going to 18 weeks might have pushed it up to 20 weeks because they felt like there's nowhere else to go. This is what we can do this, and they sort of push things. So with respect to telemedicine, one of the people in BC said, I've offered entirely telehealth abortion care for early first trimester pregnancies and minimized investigations. And this nurse practitioner said they'd moved seamlessly to no-touch medical abortions. So really, they weren't seeing people in clinic at all. So there's more and more, I would say, it's something we're studying, but it's something that's not going to go away. Many patients want to come in, but some of them really don't. And for the people in remote areas, that ability to do things through telemedicine is potentially going to improve access. So just to look at the transformation, to summarize it, 1969, it was legalized but restricted. 1988, it was decriminalized completely and considered a right under the Charter. But abortions were surgical during that time, and they were reliant on access to a physician with procedural skills and a facility that would be there to provide it. We got mifepristone finally in 2017, but with restrictions which were removed later that year, mainly. And now both physicians and nurse practitioners can provide, and we have really a change in the pattern of what type of abortion is being provided. 40% probably of all abortions are now medical. More done in the community, more done by very small volume providers doing one or a few a year. And the growth of telemedicine abortion with access to low touch, no touch, what they call self-managed abortion. This is important, and it's happening in a big way in the US. So just future directions, I think you're going to, or I know you're going to find some move to try and expand the scope of practice of midwives to incorporate abortion into what they're doing, which makes some sense. And I think we need to do some research on the safety of low touch, no touch ways of delivering this care. Question of how far is too far. If you live in an outport in such and such a community, you might have a miscarriage there, but should you be having a medical abortion there? And I think there's a lot of discussion about how far is too far, and we'd like to kind of do some more thinking about that. And then patient preferences and experiences. And just one last slide, I think. Oh, this is our study team, which is actually not everybody's really in there, so sorry, but that's the team, and I'm going to go back to this one. So I think what goes around comes around. So women are uniting our bodies ourselves. We can see we're still holding up placards, "My body, my choice." This is in Canada, this is the US, but it's a real thing there. And I think it just keeps it in our minds that these are issues that they don't really go away. Anyway, thank you.
Thank you, Dr. Dunn. Do we have one quick question for this period?
Okay, one quick question. With more medical abortion, was there a move towards earlier abortions, and is there an impact on safety from that? And
Well, that's a good question.
Thank you for a great talk and
You're
your
welcome.
advocacy.
Thank you. That's a great question, and we did find a very small decrease in the number of second trimester abortions in that study that went to the New England Journal, and probably that's because access to first trimester was easier and earlier, so that they didn't advance to second trimester before they presented for it. So yeah, I mean, I think we don't know for sure because people don't keep track of, is it 6 to 7, 7 to 8, whatever, in a big way, but yeah, I think we're seeing very early ones, including just like my pregnancy test was positive 2 days ago. Can you give me something for that? Yeah.
Great. So we're just going to take a short pause in our live stream, and we'll just have a short break here before we start our panel discussion. right. Welcome back, everyone. We're here with our 3 fabulous speakers, and we have some questions that they can all take a crack at. So we'll just start off with something a little more broad. So how can we fund and design future work to be more inclusive and representative in areas of women's health research?
That's a good question. Well, I think there's already been steps in the right direction to ensure that sex and gender are at least being considered in all aspects of research that's being proposed. So particularly in in CIHR and other funding agencies, it's actually required that these considerations be part of your proposal. So I think that's really a step in the right direction. And also thinking about dedicated funding opportunities and calls would be important as well. But I think we still have work to do. I think we still there's still a lot we don't understand about how to do research that specifically sort of addresses those unique needs. Like we talked, for example, in my research, we talked about sex-based differences, but what about those differences related to gender? I gave an example of the kind of programs that we have to think about that incorporate some of those gendered issues, like putting your family's needs before your own, right? So that kind of thing has to be considered really important in when we're designing programs. So that's just my.
I have a response. I always feel like in medicine and sciences, we're really bad political advocates. And that's kind of, we have to remember that healthcare is a provincial, it's provincial funding. And we have to remember that we're voters, right? And we have the power to actually influence political policy. And we don't learn how to advocate our issues at the level of the provincial government. And we have, provincial governments right here. And so getting to know who your MPP is, influencing politics, telling politicians, listen, we have a major issue here. Like there's 70% of females are suffering with chronic pain. 1 in 5 Canadians has chronic pain. Like that's a huge number. That's 8 million voters across Canada. Like that's a big number. So I think some political advocacy is important, and changing where some of the politics go.
I think we've been pretty lucky with our current federal government in terms of some recent attention in reproductive health. They just had a call for proposals to look at tailoring reproductive health programming to various groups of, and it would be primarily women, but not exclusively women. And I think in that case, in reproductive health area, and particularly family planning, abortion, sometimes it's the men that you want to actually get more sort of research and sort of programming involving them. But just been a good call out for that. So I think there's been somewhat of an increased awareness that this reproductive health is really fundamental to people's health. And yeah, if you put the money there, people will start to build programs. And sustainability of those programs, I think, is often the question. And in this case, the involvement of communities in developing them, which I feel is, for women and just generally population-wide, getting more community involvement in how the services are, even the questions that are asked in the services that are, provided, and the research that's done, I think would be helpful.
Absolutely. Yeah, so there's this push towards communicating with political officials and maybe education at the younger level. What would you recommend would be some next steps to either implement better education at the lower school system, or some sort of political, announcements or better messaging?
Well, you look at the Bell mental health campaigns, right? Let's talk about mental health. Those are great campaigns, and we should really think about those initiatives. We're trying to work with the Ministry of Health to start that for resiliency in young girls. just if you have those ideas, presenting them even, you know, at your PTA, your teachers association, saying, hey guys, we see the trickle down effects of poor resiliency and poor coping skills in this issue. Why don't we start here? So getting involved in things that are sometimes a little bit out of medicine, for medicine.
Great. Any questions from the audience?
Hi, I'm Noah Kahn. I'm a junior fellow here at Massey. I study philosophy of technology, so this is kind of not my area at all. But it has been interesting to hear all of the various cases. And each presentation, and this question goes to all of you, had a kind of clear, kind of cut and dry calculus that, you know, here are the history, or here's the history, here are the present facts, here's why it's a problem, and then these are a host of solutions. And I'm wondering if each of you could speak to the resistance to those solutions. So what is the kind of counter argument, what is the opposing force to, you know, implementing these solutions, and how do you see yourself overcoming that, whether it's resistance in the future that you think will kind of oppose the implementation of solutions, or resistance you faced already in trying to accomplish this work?
Well, I can start. I was just telling one of my colleagues that as a next phase in the research we're doing to help implement this program that we created, that we showed was, you know, really well received for women who've had gestational diabetes. Now we're looking to try and implement it, and immediately the pushback we get is that there are insufficient resources. People are already busy. People are already, you know, full up, right? And so in order for us to adequately tackle these problems, we need to be looking at the system as a whole, use a complex system approach, and try to understand, you know, what are some of those other parts of the system that could perhaps be changed in order to allow for change, right? So I think a lot of the resistance is people are afraid of change, people are in there's actually, you know, there's actually a few different reasons. There's problem blindness. People don't see the problems. They don't recognize them. There's the issue about, you know, being too much in your own lane. You don't understand, you know, you're really busy in your own lane. You don't understand that, you know, that there are things happening outside of your lane that might make things easier for you or affecting your own lane. So those kind of things. But I don't think there's an easy answer. I think it's really kind of looking above and also engaging people at multiple levels, right? And all the possible stakeholders that are involved in this complex system need to be at the table and to come up with solutions. But it is a big task because people are resistant to change for sure.
Her answer. I think it's COVID made us realize that in Canada, and like medicine focuses on acute things, and we kind of don't take chronic diseases as seriously, or we put that on the back burner, and that's obviously an issue. So changing kind of the way medicine thinks, so that we think more of the chronic phases of life. And changing how people understand how to navigate the healthcare system, I think is huge too, because that's a big barrier for us, right? We only use it at the beginning, at the end. We don't really navigate it in the way we're supposed to. So like some teaching behind when you get a health card and how to use it appropriately, and when to visit your family physician, and what the family physician is there for, and what specialist care is there for. Because there probably won't be any more money, right? The money is fixed. It's a provincial budget. So I think making people understand how to efficiently use the healthcare system and avoid, you know, this big self-management piece. Like the onus is on you. You come and see me 4 times a year, but the barrier for patients when I see them clinically is that a lot of the work has to be done by them to lead a healthy lifestyle. And as you mentioned, another barrier is people are tapped out, right? They can't do anymore. Like poor Diane, who travels 1 hour here and back. When is she going to exercise? Like what do we do for her? But teaching people how to use the healthcare system and the self-management piece are the biggest barriers for us in the chronic pain world.
I think it's interesting, your question is interesting to me because I was talking about a very focused area with kind of finite end points, which, and I mean, there's no question in terms of the work we were doing with mifepristone, there were some actual questions we had to ask, but we actually sort of thought of a path that was probably the right path to go. Like the specifics of it maybe weren't, and what all the details of implementation maybe weren't worked out. But the specifics of seeing that there was a lot of problems with the way the regulation or the restrictions around, to providing mifepristone when it came out, we could see that that was going to be a problem. So the problem's there. And we kind of knew what we thought was the direction to go. But for a regulator to change, they needed evidence that we could provide to then say, there it is. Like, it wasn't a surprise that we found that people couldn't get ultrasounds, like we knew they wouldn't be able to. It wasn't a surprise that people, not wanting to order a drug and keep it in your office and charge for it, whatever that would take, wasn't going to work. We knew that. But until we had some numbers to go with that and some action, it might not have changed. The other things we did was work on many levels. So the College of Pharmacists out in BC said, you're the federal government. You can't tell us that our pharmacists here that are under our jurisdiction can't provide this medication with a prescription. We worked on multiple levels, but we sort of had a common direction that we thought it needed to go, and we just needed to get bits of things to provide to the right group to be able to enable other things to happen. So I think that's kind of what I would say is it depends on what you're working on. I'm in it's much more simple and more straightforward in terms of what I'm talking about, but getting evidence that written down that you actually can show what you already know is sometimes important to do. It might not be, discovery research, but getting the data is sometimes really important to show to particular policymakers or people who are making decisions at that level.
And another question from the audience?
Well, it's more a comment than a question that has to do with the different presentations this afternoon relate to, number one, the etiology of disease and pathophysiology of disease management of a certain kind, pain, and then knowledge translation in society. Mm-hmm. These are 2 or 3 different categories of activities that physicians participate in differently and can't all do all of it. So what are the priorities, which becomes political. But one of the problems that exist in society to absorb all this is the fact that knowledge of medicine and science has added so much that it is far beyond the comprehension of most people in the community who look for belief systems or reliable sources of information to make decisions. That breach between knowledge that scientists understand and where evidence-based medicine exists versus what the community can absorb is a tremendous gulf. And one of my pitches, of course, is trying to ensure that young people, when they graduate from high school, are mini physiologists. At least understanding how their body works and the difference between how their body works on a gender basis too. And I know that women are more mature in that regard because they have periods that remind them. And so menarche is a high event. And testosterone is just head bashing on the football pitch. So it's more a comment than actually a question, but just an observation that we have been discussing 3 different domains of knowledge translation, treatment, and development of evidence in terms of therapy.
I'm going to ask a provocative question. That's actually a rhetorical question. When you get to senior or late career, whatever you want to call it, you see things go around many cycles. Do you think that we, just answering your question, Noah, to what extent do we fail to learn from what we've already learned? How many times have you seen a lit review go back 10 years or 15 years, but it was all known 30 years ago or 50 years ago, or even 100 years ago? Could we save money if we actually did our work properly?
Well, thank you for that, Jillian. I think maybe I'll start.
Yeah.
So I think that's really the reason why there's been such a move to, more looking at implementation rather than, especially in healthcare, rather than, more data gathering, right? So there's been a whole slew of, there's tons of evidence, at least in my field, and I'm sure in many others, around, high quality randomized controlled trials that have shown benefits of all sorts of treatments and preventative strategies and programs, et cetera. What the big problem is that this evidence is insufficiently translated into change, true change. And so, because it's hard to do. And so it's easier for people to go back and do another trial. Partly it's the motivations that scientists have, and the way in which we evaluate and promote our faculty is around being productive, getting research grants, getting papers out. And so it's much easier to get a research grant and get papers out if you're doing something that's going to be, you're going to get doing, right? Versus taking all that evidence that's been gathered over years and then trying to actually translate it into something meaningful. That is a really hard thing to do. I'm really glad that CIHR has now launched a series of calls for implementation science grants where they want people to do just that. They don't want any more. In these calls, they don't want clinical trials. They don't want to fund programs. They want to actually fund implementation projects and want to see real action. So I think it's a step in the right direction. That's just my 2 cents.
I just want you to go back and answer his question now, because I think that's the biggest barrier. I think we've got screwed up incentives. I think it's way harder to do as Noreen knows, I know. It's really, really hard. And, you're fighting upstream battle to try to make meaningful change, whereas documenting another gap and another gap and another hole and another misrepresentation myth, it's relatively easy. So it's just hard. And policymakers change every four years, if not more frequently, so that you're never dealing with the same people. Thank you.
I'm going to make, I love to make this every time I can, is that timing is, I think, so crucial to any activity that you do research-wise. We think research is going to be a slog and it has to be hard and whatever I do. But sometimes it doesn't need, if it's the right time and there's going to be a receptive audience and it's just got that momentum, it's going to be easy to do it, or easier to do it, and easier to have an impact with it because it's not going to get lost. So I really think it's important to be strategic about choosing when to do what you kind of are thinking about doing. Like, it may not be the right time to answer that really great question you have, because it just isn't going to resonate right now in terms of the zeitgeist, I guess.
I also think we're so siloed. Medicine, you were even mentioning before, we're so siloed in our institutions, in our universities, in our professions, that it's hard. Every one of us is looking out for our own institution, foundation dollars, money, research money. It's kind of hard to work together. So if we all sat around and spoke to each other, it'd be pretty amazing how we'd see everybody reinventing the same thing in different silos.
And back to your point, and sorry if I'm speaking again, but back to your point about one of the questions I think Noah had about, how do you actually make change? And again, this is the same problem, is that everybody's so busy, everybody's in their silos, that You know, how do they make time for something new? So I think we really have to figure out a way to break down those silos, and instead of adding something new to what we're doing, actually change what we're doing, right?
You mean
So-
give something up?
Give something up.
Oh my
Yes. And replace it with something new.
Yeah.
That is hard for people,
Yeah, it
because people like the security, not just people, institutions, you know, like the security of the know, of what,
Yeah.
what they know, right, versus something new. But unfortunately, it's very hard to get someone to give something up, but and it's also really hard to get things added on to an already busy plate on all levels of engagement. So it's not easy.
Lots of barriers.
And in discussing this sort of multidisciplinary, next step that we want to all work together, is there anything that you each took from each other's talks today that maybe is a new idea you want to explore?
I know we can definitely work together.
Yeah, that'd be interesting.
Well, I think I was really pleased to hear that, there's this thread across, exactly how Abhi suggested. There's this thread across the work that the three of us are doing around, how do we help support women across all levels, from disease prevention, managing, chronic conditions, to actually access to care and translate into clinical practice. But I think, finding ways to actually take that sort of those underlying unique factors that women that affect women around health, and finding ways to coordinate better some of those care pathways be really useful.
Great. And with that, I think we'll close the panel discussion and invite Dr. Reinhard Reifmeyer to give a few closing remarks. Thank you again for all of your work today.
Thanks.
Okay, thank you, Ginger. Yeah, so it's you're sort of at a buffet here, and you're having all these nibbles and things, and you realize that you've actually had a gourmet meal, right, with 3 courses, right, and then a dessert at the end. So that's what I got out of this. That's amazing. So just a couple of kind of takeaways for me. I mean, one message that sort of resonated with me is about early intervention. Doesn't matter what the condition, disease, whatever it is. Well, actually has massive benefits. And I remember there was a study done by, I think it was Mustard Fraser, about early childhood education, and there was a figure, I still resonates with my wife's a teacher, that for every dollar you invest in early childhood education, you save $7 in social costs later on. So you're talking to politicians always, well, what about this budget? You got a fixed budget. Well, actually this can save money, right? Besides making, the life of the individual better, right, earlier. So I think that's one thing I got out of this. And then the other thing is we need to get the science out of the lab, the clinic, into the public domain, right? We do great science, really amazing insights that are our scientists, our research institutes, universities are doing, but getting it into the public domain is really important. That's why I think I'm a real fan of science communication and, getting the messages out there in a kind of a digestible way. And obviously that, those are all the voters. Again, we had the question, those are the voters, right, the public. And politicians do pay attention to those folks, that's for sure. So then that informs, engage the public, then you get into public policy, and then it's, the public, the decision makers, who, as Julia, they have a 4-year mandate unless you're the Prime Minister of Britain, which might be a little shorter these days, maybe a few months, but anyway, but they do respond, right? So they do respond, but you have to speak their language to do that, right? I think this idea, if there's some campaigns, if you can engage, the private sector, well, it's Bell Media, Rogers, these people have big, scope across, and say there's something you could do to help us get this message out to the public, and again, the decision maker would take place. So I think this is great. And then we talked about, I think Abhi's comment, we all work on incentives. We all, we're human, right? Whatever, it's a chocolate bar when you're a kid, you behave yourself, I'll give you a chocolate bar. Okay, I'll do that, right? Whatever. But there's these sort of perverse incentives we talked about, I have to take care of my career, I'm worried about my promotion, I have to make my chair happy, by institute, I gotta get my grant renewed, and how do you do it? Well, we're on this treadmill of papers and publishing, right? And that's it. So I'm very glad that CIHR, so the higher up levels have said, well, we gotta move this stuff away, and money's always an incentive for researchers, right? They sniff it out. We're good at sniffing out money, right? It's very precious, but we're good at sniffing it out and working together and coming up with something new. I think that's really great. So I think that's what sort of I took. So I think my bottom line is, honestly, I'm an optimist, so I say systemic change is possible, right? It is possible, but you got to chip away at the edges of this stuff to make it happen, right? And finally, there's a switch that flips and there is a change. All of a sudden they say, wow, I don't even know how that happened. That's great. So I learned that. So just a little, again, advertisement for Friends of CIHR. I am the treasurer of the organization. I'm not asking for money this time, but anyway. So we have these booklets. There's some available outside at the front desk there about our Friesen Prize winners have sort of immortalized, as Albie would say, their lectures in a book format. And I would say that our current Friesen Prize winner is Dr. Lauren Terrell. I think most people know him as Dean of Medicine at the University of Alberta, and works in the hepatitis field. So he'll be coming to U of T and the hospitals on November 16th, so pencil in your kind of calendar. It'll be a public lecture at Sick Kids, I think is what we're organizing, and we'll have some events here as well. Yeah. So I was going to turn it back to the two co-hosts, junior fellows, who have done an amazing job. And I'd like to thank them for what they've done, and I'd like to thank the people who came out for the presentations as well. So thanks. Back to you guys. Thank you.
All right, so we won't keep you any longer, but we just wanted to thank you for coming today. It's been an honor to plan this event and to have you speakers here. We're really happy with how it went. So thank you so much for joining virtually and in person.
Thank you. Thanks for having us. Thanks.